Okay, good evening, everyone. I hope my audio and video is fine. Can you just give me some quick thumbs up to see whether the audio and video are fine? And let me just check it. Yes, okay, yeah. Yes, so it is fine. All right. So, welcome to this radiology doubt clearing session. I have got some of the doubts from the students that I will take as the time process. But before that, I just want to tell everybody that the exam is around the corner, and I think the more doubt than the radiology that I was getting about the exam. So my personal feelings say that the exam will happen on the scheduled time. So please do not waste your time and focus on the last days. These will be game changer for your preparation, because whatever hard work that you have done in the last few months to last few years, it's a time when you can reap that. If you will waste your time, the entire efforts that you have done will go for a toss. But if you will stay focused and if you stay determined, you are not getting distracted and you are making full use of this time, definitely you can take an advantage of that. And please uh, do that. In a very unlikely event, if the exam get postponed, still you will be having an advantage if you will be reading at this point of time. So don't waste your time, rather keep on studying. That is something that will give you advantage. Now, as far as radiology is concerned, the way that the paper pattern is changing, we all know that the importance of the radiology is increasing day by day. So in the first few minutes, I will try to summarize the type of questions that you can expect in the exam. Just ask yourself that are you well versed with this. So the first pattern of question, or what I can do is I can write them down also. The first pattern of question that I think you can expect in the exam is a radio anatomy. There will be one question from the radio anatomy surely in the exam. When I say radio anatomy, what does that mean? Broadly, let me just help you out and write them down. Radio anatomy, that means an anatomical image on a radiological image. An anatomical structure will be given and you will have to mark. Usually it's a neuroanatomy, but a chest or abdominal anatomy and rarely orthopedic anatomy can be asked in the exam. The structure at the level of basal ganglia, a mid sagittal section of the brain, a section of the chest above carina and below carina, and an abdomen above the umbilicus and below the umbilicus are the standard one that the examiner asks. So these should be on your tips without a doubt. Good evening, Ganesh. The second important thing is a vascular anatomy. Examiners are fascinated about the vascular anatomy. They very commonly ask, which is this vessel? So if it's an angiographic image, just by going with the direction of the vessel, you can identify what is that vessel. If the examiner give you a celiac artery angiogram, you will be seeing that this is the abdominal aorta. The celiac artery is going to be going like this or like this. This is the small trunk. The splenic artery is going to go to the left side and the common hepatic artery is going to go to the right side. Okay. Whereas if it's a superior mesenteric artery, it is going to go down. Inferior mesenteric artery will be further down. So by looking at the direction of the vessel, you will be able to identify what is that vessel. Examiners are very fond of asking this. If it's a cross section and a vessel is asked, follow the law that we have done in the classes, line versus dot principle. Line versus dot principle. Now what is that line versus dot principle? If it's a vertical vessel that is present in the body and you take a cross section, it will be seen as a dot. It will be seen as a dot. That means all the vertically oriented vessel in the body, like abdominal aorta, inferior vena cava, common carotid artery, they all will be seen as dot on a transverse section. Whereas if it's a horizontally oriented vessel and you take a transverse section, it will be seen as a line. Renal artery, renal vein, portal vein, main middle cerebral artery, they will be seen as line. So use this line versus dot principle to identify the vessel in the cross section. That will be very, very useful for you. Okay. So, so anatomy, there will be one question from radio anatomy that is very, very likely in the exam. The second pattern of the question that is going to be there in the exam are standard images. Standard images. What is a standard image? They will give you a radiological image. They will give you a radiological image and they will ask you what is the name of the investigation. What is the name of the investigation? They can ask you CT, they can ask you MRI, they can ask you ultrasound. Last year in INI CT they asked ultrasound, and ultrasound of the thyroid. But they can ask you CT or MRI also. IVP is a standard image that they ask. HSG, they have asked at least 10 times in the past. MCU, RGU, these are more images that the examiner can ask you. They will simply give you the image and they will ask you what is the name of the investigation. That's all. So you should be able to identify all these images. I have a 1-minute radiology sessions. If you just Google it on my YouTube channel, you can see all those 1-minute radiology session where one single topic is described in a 1 minute, and they can be helpful for you. Specifically, this kind of pattern is concerned. Another important pattern which the examiner can ask you, and rather a more predictable question, is devices or instruments. I will say devices. Devices like an ET tube, tracheostomy tube, ET tube, tracheostomy tube, Ryle's tube, CVP catheter, nephrostomy catheter, DJ stent, are they present? Or if they are present, are they normally present or are they abnormally present? And this is another kind of question that you can get in the exam. See, the whole idea of spending the time is just identify that whether you are aware of this stuff or not. If you are not aware, I will try to tell you in this revision session. If I will not be able to tell you all, maybe I will make more sessions and will share it with you. Okay. Fourth pattern of the radiology question that is going to be there in the exam is standard images. Again, standard diagnosis. In the standard diagnosis, there are some images that should be on your tips. 100% that should be on your tips. What are these images? Head trauma, EDH, SDH, SAH, diffuse axonal injury, intraparenchymal hemorrhage, imaging of stroke, imaging of brain tumors, head trauma, imaging of stroke, imaging of brain tumors, brain infections, some congenital syndromes, Arnold Chiari Dandy Walker, standard diagnosis from the neuro. Then images of PNS. Images of PNS, very, very commonly asked. Radiograph as well as CT. What is the view? Which is Waters' view? Which is Pierre's view? Which is Cadwell's view? Which is lateral view? Which view is done for which sinus, etc., etc. Then spine images. Very, very important. Standard images. Spine images. Okay. Spine images could be a radiograph or MRI images as well. Radiograph or MRI images. Then standard images in the chest like pneumothorax, pulmonary embolism, pulmonary edema, aortic dissection, pleural effusion, hydropneumothorax, lung abscess, tension pneumothorax, tension pneumothorax. These are standard images which are asked in the exam. Standard images, almost out of these, if you ask me, I will say there will be at least 2 images in the paper. Out of this, if you're going to ask me, I will say there will be at least 2 images, 1 or 2 images in your paper. Okay. Then pneumoperitoneum, intestinal obstruction, intestinal obstruction. Then pediatric surgical diseases. Pediatric surgical diseases like Hirschsprung, hypertrophic pyloric stenosis, intussusception. Hirschsprung, hypertrophic pyloric stenosis, intussusception. Liver images, acute cholecystitis, chronic cholecystitis, gallstone. Renal masses. Of lately, examiners, this has become favorite topic of the examiner. Renal masses. Very, very fond of asking renal masses, which is angiomyolipoma, which is renal cell carcinoma, which is a renal cyst, and OBG images. OBG images. Images of HSG. Doppler in pregnancy. Doppler in pregnancy. Okay. So if you ask me, I can tell you that out of these, you can expect at least broadly 8 to 10 questions without a doubt. And then you're going to get questions which are core radiology questions. When I say core radiology question, you get questions on radiations. There will be at least 2 questions from the radiation in the paper. It could be radiation, it could be radiotherapy. Radiation, radiotherapy. There will be at least 4 to 5 questions on investigation of choice or next step. 2 questions on investigation of choice or next step. So just to summarize, these are the standard things that are asked in the exam from the radiology. When you are revising radiology, focus on these points. Focus on these points, quickly revise onto the radiology, and then you're going to realize that majority of the things you are able to link it with your other subjects also, and as well as you are gaining confidence. You are gaining a lot of confidence. Radiology is a very, very scoring subject. You can aim for an accuracy level close to 100%. You cannot aim for that accuracy level in so-called clinical subjects like medicine, surgery, OBG. It is very, very PSM. It is very, very difficult to reach to the 100% accuracy level. But radiology is such a subject where your accuracy level can go up to 100%, and that is why this is called as a rank deciding subject. Okay. So now I'm waiting for you to send your doubts into the comment section, and I can take up those doubts. Okay. Meanwhile, I will take up those doubts that students have shared. One of the students have shared the images of GIT, which are very, very frequently asked. So I will show you some of the images of the GIT, which are very, very frequently asked and can be asked again. Meanwhile, if you have any other doubt, any other image that you want to see, I will show you all those images right over here as a revision section. So the first image that anybody can ask you is just simple barium studies. Like this is barium swallow. This is barium meal. If you see stomach, it is barium meal. If you see small bowel, it is barium meal follow through. If you see large bowel, it is barium enema. Okay. So standard image that examiner can ask. But mostly they ask disease based question. So these are standard images that are asked in the exam. If you see markedly dilated esophagus with narrowing, It's bird beak appearance. Bird beak appearance, and this is achalasia. This is achalasia. Whereas if you see an irregular narrowing, which is slightly longer, this is called as rat tail. Rat tail, and this is carcinoma esophagus. This is very, very simple. This is called a corkscrew in diffuse esophageal spasm. Diffuse esophageal spasm. Okay. Now the point to be noted, it is very, very easy to say that this is bird beak and this is rat tail. But in the real exam, sometimes it becomes very, very difficult to differentiate them. So always look at the history. If the dysphagia is present and it is predominantly to liquid, think of achalasia. If the dysphagia is present and it is predominantly to solid, think of carcinoma esophagus. So if the dysphagia is to liquid, it is achalasia. If the dysphagia is to solid, it is carcinoma esophagus. Carcinoma esophagus. Okay. All right. All right. Special kinds of MRI sequences. Special kind of MRI sequences. So let me just open it up and let me show you some special kind of MRI sequences. So you all are aware of T1 and T2 weighted MRI. So there are three images for you over here. This is a T1 weighted MR and this is a T2 weighted MR. You all are aware of this. Why it is T1 and T2? Because in this image, gray matter is gray, white matter is white. Whereas in this image, gray matter is white and white matter is gray. The water is black here and water is white here. And we all know this wonderful mnemonic, World War II. Water is white on T2. Water is white on T2. And if the water is white, it has to be T2 weighted MR. On the other hand, T1 weighted images, we all know, is done for anatomy. And T2 weighted images are done for pathology. One of the students asked me, Ki sir, I get confused that which one is for anatomy and which one is for pathology. So it's very simple. First prof का subject है anatomy. So first prof में T1 पे anatomy पढ़ेंगे. Second prof का subject है pathology. तो T2 second prof में pathology पढ़ेंगे. So T2 is for pathology. T1 is for anatomy. Okay. Now the point to be noted is majority of the pathologies are white on T2. Majority of the pathologies are white on T2. Water is also white on T2. Sometimes it is very, very difficult to differentiate them. To overcome this limitation, another image is being created, which is called as flare. So this image that you could see is flare. The easiest way to remember flare is T2 minus water. Easiest way to remember flare is T2 minus water. That means it's a type of T2 weighted MRI which has got all the properties of T2 except water is black. So whenever there is a confounding factor of water, flare will help. In the brain, water or CSF is a major confounding factor, and that is why flare is used in the brain parenchyma to differentiate between CSF and pathology. To differentiate between CSF and pathology. So easiest way to remember flare is T2 minus water. And where will we use T2 minus water? Wherever water is a confounding factor. In the brain, major confounding factor is water. But in rest of the body, major confounding factor is fat. Like in orthopedics, my entire central part of the bone, which is spongy bone or a cancellous bone, is filled with bone marrow. And bone marrow contains fat. And bone marrow contains fat. Now, if the pathology is white, which is overlapped by the white marrow, it will be very, very difficult to see. So, T2 minus water is flare. T2 minus water is flare. The easiest way to remember T2 minus fat is stir. T2 minus fat is stir. Now, those who are radiologists or who are watching this particular video, I know that once you will become, those who are PG aspirant who will become radiologists, they will know much more detail of the T2 minus fat. Please remember, this is an easy way to remember. There are various ways to suppress the fat, but that is not important for us at a PG entrance exam level. At PG entrance exam level, as a non-radiologist, if you can remember it like this, that is the easiest way to remember. So T2 minus water is flare, T2 minus fat is stir. So where will we use stir? Whenever the fat is the confounding factor, we will use stir. And that is the reason that the stir is the most useful imaging sequence in orthopedics. Most useful imaging sequence in orthopedics. Earliest finding of ankylosing spondylitis is subchondral marrow edema in sacroiliac joint, and that is best seen on stir MRI. Best seen on stir MRI. So T1, T2, flare and stir. Next sequence. Next sequence. If you see an image of the MRI, which is a very, very blur image, where the gray white matter is not seen separately, it is smudged with each other, but pathology is literally staring at you. This is DWI. This is DWI, diffusion weighted imaging. Diffusion weighted imaging. If somebody asks me what's a diffusion weighted imaging, I will say it's a special type of MRI sequence. It's a special type of MRI sequence which assesses the Brownian motion of the water molecule. It's a special type of MRI sequence which assesses the Brownian motion of the water molecule, which is a normal phenomena. In certain diseases, this Brownian motion is blocked. In certain diseases, this Brownian motion is blocked, and this is called as restricted diffusion. This is called as restricted diffusion. Please remember, areas of restricted diffusion are seen as white on DWI. Areas of restricted diffusion are seen as white on DWI. Most common cause of restricted diffusion. Most common cause of restricted diffusion is acute ischemic infarct. Most common cause of restricted diffusion is acute ischemic infarct. However, it can also be seen in high cellular tumor, epidermoid cyst, high cellular tumor, epidermoid cyst, abscess and encephalitis. Acute ischemic infarct, high cellular tumor, epidermoid cyst, abscess and encephalitis. Okay, so T1, T2, flare, stir, DWI. These are the 5 important sequences that everybody must be aware of. There are some special sequences like this. This is MR angiography. MR angiography, which is done with a special sequence, which is called as time of flight imaging. Time of flight imaging. Time of flight imaging is a special type of MR angiographic sequence, whereas an angiography can be done even without contrast. Where an angiography can be done even without contrast. This is the next sequence. This is called as spectroscopy. Okay, spectroscopy. I will expect some answers from you in the comment section in spectroscopy. Do tell me the answers. Spectroscopy. What are the common metabolites that are assessed in spectroscopy? Common metabolites that are assessed in spectroscopy. Write down in the comment section. Yes, NAA, choline and creatine. NAA, choline and creatine. NAA is a neuronal marker. NAA is a neuronal marker. It's a marker of neuronal integrity. What we need to remember? It is decreased in all disorders. Who will write it first? Any disease which shows elevated NAA. Any disease in the body which shows elevated NAA. Answer is Canavan's disease. Answer is Canavan's disease. Canavan's disease can show increased concentration of NAA. Okay. Whereas choline is a marker of cell membrane turnover. Choline is a marker of cell membrane turnover. It is increased in malignancies. It is increased in malignancies. Whereas creatine is a reference marker. Creatine is a reference marker. Creatine tells me what has increased or what has decreased. Okay. Now who will answer this? Apart from NAA, choline and creatine, which are the most important markers, which are the other markers that can be seen in spectroscopy? Apart from NAA, choline and creatine, which are the other markers that can be seen in the spectroscopy? Lipid lactate peak. Lipid lactate peak. Yes, alanine, lactate, etc. can also be seen. But please remember, lipid lactate peak is a very important way to differentiate neurocysticercosis from TB. Lipid lactate peak is a very important way to differentiate neurocysticercosis from tuberculoma. Tuberculoma shows lipid lactate peak, whereas NCC will not. NCC will not. Okay. All right. What are these? These are three more important sequences. Okay. Yeah. You can also send me WhatsApp if you do not want to write on an open platform and you want to ask a doubt to me. Those who are with us and have my number can simply send me a WhatsApp also with your doubt. Okay. Now this is an important sequence which is SWI, susceptibility weighted imaging. Susceptibility weighted imaging. Now susceptibility weighted imaging is very important to differentiate hemorrhage and calcification on MRI. Susceptibility weighted imaging is a very important sequence to differentiate hemorrhage and calcification on MRI. Previously, we used to say that the hemorrhage and calcifications are not very well seen on MRI. Then we got a sequence which is called a GRE, gradient recalled echo. They used to pick up hemorrhage and calcification, but both look similar. SWI is a further advance to that, where the hemorrhage and calcification can also be differentiated. If it follows blood vessel, it is hemorrhage. If it follows bone, then it is calcification. Okay. Another important point about SWI, it's a very useful sequence for microhemorrhage. It's a very important sequence for microhemorrhage. Anybody who can tell me 3 important diseases in the brain which can show microhemorrhages? 3 important diseases in the brain which can show microhemorrhages. I am waiting for the answer. The first is diffuse axonal injury. Second is hypertensive encephalopathy. And third is amyloid angiopathy. Diffuse axonal injury, hypertensive encephalopathy, and amyloid angiopathy. If there is a history of trauma, answer will be diffuse axonal injury. If there is a history of hypertension, the answer will be hypertensive encephalopathy. All the 3 patients will have altered sensorium. Altered sensorium with trauma, DAI. Altered sensorium with hypertension, hypertensive encephalopathy. Now who will tell me when the answer will be amyloid angiopathy? When do you think the answer will be amyloid angiopathy? So simple. If trauma and hypertension is not given, then answer is amyloid angiopathy. If trauma and hypertension is not given, Then the answer is amyloid angiopathy. Okay. All right. Now see this. If you see this kind of image, when there is a colored structure that is given, this is a special kind of MRI which is called as functional MRI. Which is called as functional MRI. Functional MRI is done with a special sequence of MRI which is called as bold imaging. Bold imaging. Blood oxygen level dependent. Blood oxygen level dependent. Now, bold MRI is a special type of MRI which is done to assess eloquent cortices of the brain like motor cortex, language area, visual cortex, etc. Those eloquent or the essential areas of the brain are best seen on bold MRI or a functional MRI. Okay. The last image that you can see behind me, which is faintly visible, but you can still appreciate it, which is like a colored image, which look like an angiographic image. But if you see it carefully, it is basically outlining the white matter of the brain. So once it studies the white matter, this is called a tractography. Tractography, which is done with a sequence which is called as DTI, diffusion tensor imaging. Diffusion tensor imaging. Diffusion tensor imaging is a very important sequence that you all have to be aware of. Diffusion tensor imaging. Just give me a sec. Diffusion tensor imaging. Okay. All right. So these are the important sequences of the MRI that I feel is commonly asked. All right. Now, different kind of ultrasound for the lung pathology. Okay. So lung pathologies, let me just show you. So as far as ultrasound is concerned, I don't think that the examiner can ask you more than the EFAST for the ultrasound of the lung. The chances of getting a non-EFAST ultrasound of the lung is extremely unlikely, because in general ultrasound images are very difficult to interpret just as a single image. But yes, because in the past those images have been asked, I'm just gonna quickly show you the images. Just give me a sec. Yeah, so you can see this image. Now these are the B mode and the M mode ultrasound of the normal lung. B mode and the M mode ultrasound of the normal lung. On a B mode, the parietal and the visceral pleura are sliding over each other, which is called as sliding pleura sign, which is normal. Whereas on M mode, you can see a clear-cut demarcation between the parietal and visceral pleura, and no movement above that, and a grainy appearance below that, which is called as a seashore sign. So seashore sign and sliding pleura sign. Seashore sign and a sliding pleura sign, both are normally seen. Both are normally seen. Sliding pleura on B mode, seashore on M mode. Whereas if the seashore is being replaced by straight parallel lines like this, this has been called as a stratosphere sign or a barcode sign. Stratosphere sign or a barcode sign. And if there is air comes between the parietal and visceral pleura, you will not be able to see this sliding movement, which is called as a loss of sliding pleura sign. So loss of sliding pleura sign on B mode and stratosphere or a barcode sign on M mode is a sign of pneumothorax. Is a sign of pneumothorax. I don't think that apart from image of the pneumothorax, any other ultrasound based image can be asked in the exam. Okay. Now, since we are talking about ultrasound of the lung pathology, I want all of you to be aware of a terminology. Anybody who can tell me, I'm just writing the name. Anybody who can write me the full form of this? What is the full form of this word? POCUS. Full form of POCUS. Anybody? POCUS stands for point of care ultrasound. Point of care ultrasound. Now, this has been a terminology that has been introduced stating that ultrasound is a very, very good investigation and it should be available at the point of care in the emergency setting. The person who is handling the emergency should be able to handle the ultrasound by identifying some of the diseases in a very, very quick way. That is called as point of care ultrasound. Point of care ultrasound. That means in the casualty, the ultrasound machine has to be available for a quick diagnosis of a particular condition. So it has been seen that a lot of diseases, including consolidations in the lung, pulmonary edema, that B lines or a curly B line that we talk of, can be easily identified on ultrasound. In fact, when the COVID happened, a lot of patients went for CT scans. If you look at the standard guidelines which were released by All India Institute of Medical Sciences, which says that the CT should not be done commonly if a POCUS is available, if a point of care ultrasound is available, because what is the characteristic finding of COVID? The characteristic finding of the COVID is peripheral areas of ground glassing or consolidation. If they are touching the pleura and they are peripheral, those areas of consolidation can be easily seen on ultrasound, and you are potentially saving the patient from high dose radiations of a CT scan. Okay, so these are the broad points from the ultrasound of the lung that I feel that you should remember. Costo diaphragmatic angle. But its significance, costo diaphragmatic angle has lot of significance. Let me explain it to you with the images. See this image. Okay, so see, first of all, understand what is a costo diaphragmatic angle. Costo means rib, diaphragmatic means diaphragm. So this is called as a costo diaphragmatic angle, which in a common language is called as CP angle or a costophrenic angle. Costophrenic angle. Now, if the patient is in erect position and there is a pleural effusion, the fluid gets accumulated here. The fluids get accumulated here and it gets blunted. So blunting of a CP angle like this is a sign of pleural effusion. Blunting of CP angle is a sign of pleural effusion. But what is the commonest mistake that we do? We think that this is the most dependent part of the chest in erect position. That is wrong. This angle that we are seeing is a lateral costophrenic angle. If the patient is erect, the posterior costophrenic angle is a much deeper than the lateral. So fluid first goes posteriorly and then it comes laterally. At least 150 ml of the fluid is required to cause its blunting. At least 150 ml of the fluid is required to cause the blunting of the CP angle. And that is the reason in patients who have got less amount of fluid, we cannot see a blunting. Then we tilt the patient into the lateral decubitus position, and as little as 10 to 15 ml of the fluid can be seen on a lateral decubitus position like this. Like this, if you do this, all the fluid comes along the lateral chest wall. As little as 10 to 15 ml of the fluid can be seen over here. As little as 10 to 15 ml of the fluid can be seen over here. Okay. All right. Vivek, just give me a sec, bache. What is the difference between radiotherapy and chemotherapy? Bache, radiotherapy and chemotherapy are totally different. Radio means radiation. Chemo means drug. Treatment of cancer using radiation is radiotherapy. Treatment of cancer using chemotherapeutic agent is chemotherapy. So both are poles apart. Okay. CT of the paranasal sinuses, Onodi cell and the Heller cell. Yes, that I can tell you. Okay, yeah. So Vivek, I am aware of this question that was asked in the exam. Uh, uh, I can tell you the appearances of these because as far as their algorithm, their treatment pattern is concerned, that is more of a question from the surgery. And since it's a controversial topic, I do not want to increase your confusion into that because already there is a confusion between two prominent surgeons who are teaching on various platforms about the different answers. All I can say is that look at the area. Just let me go to my this pattern. Go to the area. So do you have got aorta? You got common iliac, external iliac, internal iliac, and then the femoral. So if an angiography is given, see, it's the simplest concept of bypass, according to me, is whenever there is a block, just bypass it. And then just bypass it. But for the femur, it is says if there is just you are seeing an area which is blocked, then from the one femur to another femur, the vessel can also be given. So it totally depends that what is the exact level of block, what kind of bypass that you want to provide. The ultimate concept of bypassing is you want to maintain the distal flow. So one way of maintaining the distal flow is this. But if the remaining part is difficult to access or you are unable to go, then the other femur can be used to provide the bypass, provided that area has got absolutely normal blood supply. Okay. All right. So now let us see some of the CTs of the paranasal sinuses. Yes, and maybe these variants. AIMS people are very fond of asking this. So let me just take out one of my PPT for it. Okay, let me show you some of these images. So this is one of the image that was asked in the AIMS exam. Now we all know that this structure that you could see is the inferior nasal turbinate. This structure that you could see is the middle turbinate, and at the top of it there will be superior turbinate. And if there is a pneumatization of the superior turbinate, this is the pneumatized superior turbinate, which was asked in the AIMS exam. However, if you see this image, you can see the inferior nasal turbinate and you can see the pneumatized middle turbinate. You can see the pneumatized middle turbinate, and if it is pneumatized middle turbinate, this is called as concha bullosa. Concha bullosa. Now, apart from concha bullosa, you've got two more cells that you need to be aware of: Heller cell and Onodi cell. Heller cell and Onodi cell. तो देखो दो तरीके याद रखने के. O for Onodi, O for optic nerve. O for Onodi, O for optic nerve. Okay, one. Second, H comes before O. So H is anterior, O is posterior. H is anterior, O is posterior. Okay, so Heller cells are anterior, Onodi cells are posterior. So this cell that lies in the relation of the optic nerve over here are called as Onodi cell, and these cells which are anteroinferior along the anteroinferior orbital wall are called as Heller cell. They have significance in FES. If they are not being reported in the CT of the paranasal sinuses, they can get injured and they can cause injury to the associated structure. Okay. All right. There's a very controversial question, and that is, what is the first view or first place to be checked in FAST? Okay. So let's see this. Let me just tell you the controversy. Please see to it. Now, FAST, focused assessment by sonography in trauma. Focused assessment by sonography in trauma. The aim is to look at the fluid collection. The aim is to look at the fluid collection. Please remember, the aim of the FAST is not to look at the visceral injury. So the book says the most dependent part of the peritoneum in the supine position is Morrison's pouch or a hepatorenal pouch. And that is the reason this is the liver and there's a kidney over here. And in between the two, there is a hepatorenal pouch. So they say the first place that you check is the right upper quadrant. Right upper quadrant to look for the perihepatic space and the Morrison's pouch. And then it says, look at the subxiphoid space. Look at the subxiphoid space. Now, why you are looking at the subxiphoid space? You're looking at the subxiphoid space to look for the pericardial fluid. And then you look at the left upper quadrant. And then you look at the suprapubic for the pelvic fluid. The left upper quadrant is for spleen and suprapubic is for pelvic fluid. So according to this, the answer should be right upper quadrant. But then the ATLS guideline says that the first place to be checked is subxiphoid, because the instability of the patient could be because of a pericardial effusion, and that can be treated there and then. And that is what says the first place that you should check is a subxiphoid. Now, the controversy is there between the radiology literature and ATLS guideline. Now, what I should mark? If you ask me, I will say if the examiner asks what is the first place of the abdomen to be assessed in FAST, first place of the abdomen to be assessed in FAST, it has to be right upper quadrant, because pericardium is not abdomen. If in general somebody asks me what is the first place to be checked in FAST, it should be subxiphoid, because the possibility of this question being asked from a surgeon and from an ATLS guideline is much more likely from the radiology. Okay. Yes, if somebody specifically mentioned the question, first site of the abdomen to be assessed in FAST, it has to be right upper quadrant. Overall FAST, if you ask me, subxiphoid. Okay. E-FAST, you add right and left pleural cavity also for a pneumothorax and hemothorax. Clear? But the T1 and T2 weighted image I have already spoken, Priya. You can scroll back the video, and in the video you're gonna see it. Okay. Yeah, in a supine position it is hepatorenal pouch Ganesh, in a standing it is pouch of Douglas. Okay. All right. Simran, in pleural tapping, what is the most ideal site of puncture? Which intercostal space? So, bache, we live in the world of radiology, and we people are diagnostic focused people. We say there is no ideal space. Look at the ultrasound, and wherever you see maximum fluid, take out the fluid from that area. When you practice radiology, your life becomes so focused about the radiology that if you have to see whether the patient is alive or not, you don't look at the pulse. You place your probe onto the heart to see whether the heart is beating or not. And that is how, that's focused our life usually become. So if somebody have to do a pleural tapping, I will say, why do you want to do a blind tapping? You simply place your ultrasound probe, and whichever is the side where you see the maximum amount of fluid, under the ultrasound guidance, take it off. Okay. So we don't believe that it is the 5th intercostal space or an 8th intercostal space or a 7th intercostal space. It should always be ultrasound guidance. Okay. Because this space will vary depending on which line, whether you're doing in an anterior axillary line or a mid axillary line or a posterior axillary line, depending on how depth is the pleural effusion. Do you know, I have seen lot of mishappenings because of that. And as a young doctor, I want to advise you, all these procedures nowadays should be ideally done under ultrasound guidance. I have seen lot of people have done biopsies without ultrasound guidance. I have seen people have done liver biopsies using ultrasound guidance, and when the pathology result came, it shows anthracotic pigment. It shows anthracotic pigment, and people are thinking, which liver disease shows anthracotic pigment? Anybody who can tell me which liver disease will show anthracotic pigment? Yes. Okay, so yeah, so basically he has taken the biopsy from the lung, not the liver. That's the challenge. Okay. Best investigation to assess the integrity of the implantable cardio defibrillator, it is X-ray. X-ray. X-ray is considered to be the best investigation to assess the integrity, because it is usually the wire that gets broken, and those wires, the integrity of the wire is very well appreciated on a plain X-ray. This question has been asked in older AIMS exam, and you have to know this answer. Yes, correct. It was a lung biopsy. It was neither Dubin-Johnson nor berylliosis. It was, instead of a liver, the sample of lung was obtained. Okay. Okay, Wilkinson syndrome or a superior mesenteric artery syndrome. Yes, that I can also tell you, and I can tell you with the help of a question. Let me just quickly show you a question. This was the exact question that I have given in one of the TND also. This can help you out. So this is a typical image of a superior mesenteric artery syndrome or a Wilkinson's syndrome, whereas what is happening is this is duodenum, first part, second part, third part, and the fourth part of the duodenum. The third part of the duodenum is crossing from right to left, and this is the aorta. Aorta gives the superior mesenteric artery. So if I tell you a lateral view, this is the aorta and this is a superior mesenteric artery. So the third part of the duodenum is passing between them. Now, if the angle between the aorta and the superior mesenteric artery gets narrowed, it compresses the third part of the duodenum, and as a result of which it presents as a sign of intestinal obstruction. It usually happens when patient loses the weight suddenly and the mesenteric fat get lost. So this is called as a superior mesenteric artery syndrome. Thanks, Imranul, and I hope you will get. Okay, so I am assuming that you are doing pretty well in the life. It's been more than 7 years that you have cracked. So wish you all the best, bache. Yeah. So anybody who can tell me what is the treatment for superior mesenteric artery syndrome? What is the single most important treatment for a superior mesenteric artery syndrome? Weight gain. So once you do a weight gain, that angle become widened further and you can avoid a potential surgery. However, if it doesn't work, then duodenal or duodenal anastomosis is the next way. Okay. All right, guys. So those were the important points, or I tried to answer your doubts, whatever best that I could do. And this is the list that I have shared in the beginning. Those who have joined the session late, please remember there are a lot of radiological questions asked nowadays. These are standard questions. If you spend half a day in revising radiology, you can get an advantage of at least 4 or 5 extra questions, which means 20 to 25 marks, which can make a lot of difference to your rank. Do let me know if I can help you out in any other way. Do try eGurukul 3.0. We have worked a lot on the eGurukul 3.0. We have taken all the critics, all the suggestions in a positive way. The English videos are coming up. The question bank has been updated in a very good way. Do try that, and I'm very sure that it will change your preparation in a great way. Okay, all right. Thank you very much for your time, and I hope it was a helpful session for you. Do let me know if we can do anything else for you. We will be more than happy to provide you the content to help you in the best possible way. Okay, take care and all the best.